Society of Anesthesiologists, Puthukkottai City Branch, and the focus of today's session is Thoracic Surgery-Lung Resection. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Meenakshi Sundaram Sir, the Honorable Academic Chairperson of ISA Puthukkottai Branch, to start the event today with his enlightening words and for the further coordination. So, over to you, sir. Please proceed.
Thank
The
you.
dice is all yours.
Thank you, Clearnet. Thank you very much. At the outset, I request Dr. Munian, President, ISA Puthukkottai City Branch, to offer his presidential address.
Good evening to all, Madam, Sir. It's my honor to welcome you all for the online webinar conducted by Puthukkottai City Branch, Tamil Nadu, in the name of Puthukkottai Bhudhan. We have successfully conducted 6th online webinar. Today we are conducting 7th episode. Our association represents the collective voice of our specialty for the highest standard of anesthesia care, research, and our CME program, like our online webinar program conducted by Puthukkottai Bhudhan. Since we are the reputed high standard anesthesiologists, we play a vital role in ensuring the patient safety during surgery and other medical procedures. Last time we conducted online webinar in the name on the coronary stent anesthetic implications by Andhra Medical College in Visakhapatnam. More than 870 delegates are attended. Every week our association online webinar delegates are increasing. Thanks to our professor and academic session at the Today we are conducting online webinar in the name of thoracic surgery and lung resection. There are 3 speakers and 1 moderators are available. Here's a discussion of lobectomy by Dr. Mandeep Singh Sigla, fellow in thoracic anesthesia, Medanta Medicity Gurugram. Welcome, sir. And perioperative evaluation and the patient periodic evaluation of patient posted for lung resection by Dr. Dinesh Kumar Sigla, Associate Director, Medanta Medicity, Gurugram. Welcome. Lung isolation and intraoperative management for lung resection by Dr. Mukesh Kuamr, samplay, Associate Director, Medanta Medicity, Gurugram. Welcome, sir. The whole session will be moderated by Dr.Sangeetha Khanna, Director, Medanta Medicity, Gurugram. Welcome, madam.
Thank you.
In India is being a tropical as well as agricultural country, having a high burden of lung disease, including cancers and non-cancer conditions. Thoracic surgeons in India focusing mainly on the treatment of lung cancer, esophageal cancer, emphysema, and lung transplantations. Today, there is advancement of in the thoracic surgery by VATS, video-assisted thoracoscopy surgery, which will offer patients post-operative stay. It will also reduce the post-operative stay, blood loss, and post-operative pain also less in video-assisted thoracoscopy lung surgeries. To reach the high standard goal, the anesthesiologist should concentrate careful evaluation of the preoperative conditions like spirometry, ABG, diffusion capacity, and the X-ray, and the coexisting conditions regarding cardiovascular system and diabetes and hypertension. And the induction will be, and the intraoperative management, the induction, we know the induction agents, ketamine, hyopendan, propofol, we can use according to the patient's conditions. And maintenance by
I think
it's also reduce the post-operative pain management and also reduce the opioid requirements. One lung ventilation indicated to isolate the lungs from to spillage or contamination from the diseased lungs. The methods are used for double lumen tube and single lumen tubes, the bronchial blockers or endobronchial intubations. Post-operative care, monitoring the patient, closely monitoring is very much important during post-operative period. Cardiac system and respiratory system. Pain management, as I already told, epidural anesthesia, epidural analgesia, gold standard for post-operative management and to reduce the sedation. Early ambulation, we have to encourage the patient for early ambulation to reduce the post-operative stay and long bed stay due to escape complication like DVT. Today we gather the online webinar by the eminent speakers, and they are also excited to share their experience in their hospital with us, with all of us. And I look forward our discussion, debates, and networking opportunities. Welcome you once again. I welcome you all. Thank you, sir.
Thank you, Dr. President Dr. Munian. Now I request Dr. Kannan, our Secretary, Puthukkottai City Branch, to offer the Secretary's report.
Thank you, sir. Good evening, all. I am Dr. Kannan, Secretary, ISA Puthukkottai Branch. We Puthukkottai ISAs successfully we are conducting the 7th webinar of Puthukkottai Bhudhan, and today our topic is thoracic surgery and lung resection. I welcome all our honorable speakers to the webinar, and our President Dr. Munian sir has given a brief elaboration of the topics. And last week, 26th February, our 6th webinar was conducted smoothly with enthusiastic speakers. The 6th webinar topic was coronary stent and its anesthetic implications. The topic is very much needed and it was very useful to all. And we split the topic into three. First one, physiology of coronary circulation, and the second one is coronary stents, and third one is anesthetic management of coronary stents. Physiology of coronary circulation was done by Dr. S. Vignesh, postgraduate, Andhra Medical College, and Dr. Vignesh shared perfect diagrams of heart and the coronary circulation. He has elaborated the physiology of coronary circulation with easily understandable slides, because the basics of anything is important in our field. He has nailed it. And the second one, coronary stents, topic done by Dr. A. Rajasekaran sir. He is a retired HOD, Department of Anesthesiology, Majors General Hospital, Saudi Arabia. And sir has explained different types of the stents and its implications, because the implications varies to different types of stents. And the slide shared by the sir was very excellent. And the anesthetic management of coronary stents, patient for non-cardiac surgery was done by Dr. P. Satish Kumar sir. He is Associate Professor, Department of Anesthesiology, Andhra Medical College, Visakhapatnam. Sir has explained the anesthetic management, which was the theme of the last webinar. Sir has explained all the types of management in anesthetic management with different slides. And our moderator was Dr. Vijis Venugopal sir. He is Principal, KMCT Medical College, Calicut, Kerala. And the webinar was attended by 870 delegates in the last time. Thanks all for your kind support, and we need your kind support to continue the greatest webinar in India. We ISA Puthukkottai thank our academic chairman Dr. Meenakshi sir, and we will aim 4-digit figure of delegates attendance in the upcoming webinars with our consistency in quality. Thank you, sir. Thank you all.
Thank you, Secretary sir. And now it is my duty to offer that thematic speech. As academic chairman of this Puthukkottai Bhudhan, I want to inform all of you that we are successfully running the 7th episode, and we have compulsory included postgraduate, but who will be having only 10 minutes time. So Dr. Mandeep Singh is doing that job of 10 minutes because he loves cricket. So I think all the others can switch off the mic. Dr. Mandeep Singh, being a cricketer, he will easily hit a century. So within 10 minutes, he will do his job. And Dr. Mandeep Singh is from Hoshiarpur, and he has graduated from Patiala, and he has finished his DPNB, and now he is doing his fellowship in thoracic surgery. Actually, I used to call these type of people as pseudo PGs. He's a qualified person only. He's once MD qualified, he's a qualified person only. But now he is posing as a postgraduate here. But it is our honor to have a trainee to deliver a lecture. It will be attended others by Dr. Mukesh sir. So, Dr. Mukesh, I want to tell, sir is having more than 20 years of experience in thoracic surgery alone. He is full and full engaged in thoracic surgery. So, we will inform the people that you are my heart. You are my heart. Whenever we love someone, we say you are my heart. But he used to say you are my lung. That is his point. And see the perfection which I liked from his. We have titled this webinar as thoracic anesthesia pneumonectomy. But see, he was not ready to accept that. He said it should be labeled as a lung resection only because we may go for segmentectomy, we may go for sleeve resection. These are all we have heard, sir, but we have not seen. So probably that may be the reason we would have labeled it as pneumonectomy. But even I can convince Dr. Sangeetha madam. Madam, this is only for title sake we are putting, but this man is not ready to leave me. Then I was forced to change. It is thoracic surgery, lung resection. So he is very careful about the wordings because that is what exactly he is doing day to day. See, when we are doing 2 lobectomies per month, these people are doing 20 lobectomies per day in Medanta Medicity, which I have seen in the Gurugram. So now these people have come, and Dr. Mukesh is instrumental in performing the total intravenous anesthesia. He is interested more in remifentanil, which we have not seen so far. So he is interested in that. Ativa, he is interested in playing volleyball. The other two people are cricketers, but this man is interested in volleyball and football. Volleyball and football. So, but I will tell you, all of you, only one introduction about him. You may be thinking there are 7 wonders in the world, but I think he is the 8th wonder. That is the only thing I can say. He is the 8th wonder for the simple reason he is not having a WhatsApp account. So he should really be a 8th wonder. I don't think that anybody will have, sir, you may be a 8th wonder, but which is creating hell a lot of problem for me in communicating him. That is a big issue. So you consider poor people like us. So you have a WhatsApp account to allow someone and to block all the others because it is very difficult to communicate. Every time I remember, oh, we have to drop a message for this gentleman. Another problem is if we are not having an iPhone, then you cannot communicate to him at all. That is a problem. We cannot put any flyers, everything. So I think he will consider our request to be kind enough to come out of the 8th wonder in the world. You need not be a wonder, sir. You be a friend for us. So you come and join in the majority in line because it is very difficult for contact. Probably madam may be contacting you for duty schedule. So you have not created a WhatsApp account, but we will not disturb you like that, sir. So please you block madam's number and allow us to post you in the WhatsApp. So I think it will be done in future. And he will be assisted by Dr. Sigla. Dr. Dinesh Sigla was constantly in touch with me even before this webinar. It is quite nice to see these people are not ready to project themselves. They say, I am an associate director, Medanta Medicity. That's all. They don't want to say anything more because it is close to their heart. They want to be identified like that only by their profession. But we people are interested in showing our extracurricular activity. These people are having only involution and they are not exposing their talents. And after a lot of pressure, he has accepted that he is interested in playing cricket, but now he is not playing cricket because madam is not allowing. So he is engaged only in the hospital activity. So he has specifically mentioned, sir, I have played only in college, but after that I have never done anything, doing only lobectomy. He is doing only lobectomy after that qualification. So he is also, we are fortunate to have him as a faculty and to govern all these 3 people, the top end people, all 3 are qualified. This is the first time we are having all 3 are qualified because this PG is not a PG. He's a qualified PG. So now they are controlled by none other than Dr. Sangeetha Khanna, a great lady who is dedicated, passionate in teaching. She loves teaching students. See, madam, I have seen as the organizing secretary of the Gurugram conference. It is the 70th ISACON organized in Gurugram. And I was fortunate to moderate this session in which madam was participated. She immediately takes decision. Once one workshop is forced to cancel, she immediately places the faculty in other position. So she can put the tube in the right side or left side or middle. So she can do anything. So she has shown her prowess in that. And madam is having so many international and national publications. More than 50 she has. And she's the director of all directors. She's a senior director of Medanta Medicity. And madam is a fellow of Indian College of Anesthesiology. She is playing an instrumental role in Airway Foundation. And these are all our academic details. It is easy for anyone to achieve. But in addition to that, madam is a good Bharatanatyam dancer. That's what I want to inform all the people. She's a good Bharatanatyam dancer. And now in Medanta Medicity, she is not dancing. She is making others to dance to her tunes. That is what is happening in Medanta. You have to see the Medanta Medicity performing in thoracic surgeries. It is quite nice to see. They have individual specialties for all the surgeries, and madam is instrumental in projecting them, in shaping them, and we are happy. So far, our average viewership is around 800. We want to push it to 4-digit figure. So with the Medanta Medicity giving the way, paving the way for this, I think now I had so many inquiries about this thoracic anesthesia symposium. That means it shows how important it is. And the department which is participating in the symposium is noteworthy, having a good reputation. And with all my wishes, I hand over the session to Dr. Sangeetha Khanna to proceed. Thank you, madam.
Thank you, Dr. Meenakshi. I think that's a very generous introduction for all of us. You have really, lifted up our egos and boosted our morale. So I think we should have a very healthy discussion at the end of it. So really thank you for inviting us and giving us this opportunity. And I think we start our session today. So what we've decided is we will first start with general introduction about lung, how we optimize our patients, which will be done by Dr. Dinesh. And then Dr. Mandeep will present a case and exactly how it needs to be done. And then finally, we will have Dr. Mukesh, who will take us to the intraoperative and perioperative management of this patient. So without wasting much time, I think we'll hand over to Dr. Dinesh, who can start with his preoperative workup for a patient who comes for a lung resection.
Yeah, thank you, ma'am. Thank you for giving me this opportunity. And I will also like to thank Dr. Meenakshi for giving me this wide platform to connect with the large number of audience. So, I will open. Is my screen visible? Yeah. Okay. Good evening, everyone. So my topic is preoperative evaluation of thoracic surgery patient. How to optimize the outcome. So thoracic surgery is being done for large number of cases. It can be for diagnostic involving the airway, lung, or intrathoracic structures. Or previously, lung resection was being done for mainly infective procedures like empyema, bronchiectasis, or lung abscess. But nowadays, most common cause for lung resection is malignancy. Nowadays, for surgery is also being planned for end-stage pulmonary disease like lung transplantation and lung volume reduction. Recent advances in anesthesia management, surgical techniques, and perioperative care has expanded the scope of resectable lesion. So today's discussion will be around the lung resection for malignancy. A basic principle for any lung resection, or to say any lung surgery, will remain the same. We anesthesiologists are not there as a gatekeeper. We are not there as only for the giving the clearance to patient for surgery. We have to identify the patient at elevated risk, stratify our perioperative management, and optimize any modifiable risk factor and focus our resources on high-risk patients to improve the surgical outcome. In evaluation, we have to evaluate that whether patient can withstand the planned resection or not. It should not be there after the surgery, patient become respiratory cripple or he is limited to the hospital or ICU. And it is imperative for an anesthesiologist to have the complete knowledge of patient's medical status and appreciation of pathophysiological of a lung resection surgery. As an anesthetist, we may be seeing the patient at the end of referral chain. Patient surgery is already planned and decision has been taken. But sometimes in high-risk patient, our opinion may be taken. Or in the intraoperative period, when the planned surgery has to be extended due to some lesion and lobectomy may have to be converted to pneumonectomy. We may have to ask our opinion. We have to have a complete understanding of patient pathophysiology and medical status to give the decision. Major cause of complication in respiratory lung resection is cardiac and respiratory. Incidence of the respiratory complication is around 15 to 20% and account for majority of the expected mortality, that is 3 to 4%. Cardiac complications are second most common. Most common are arrhythmia and ischemia. They occur in 10 to 15% of thoracic population. So we will be discussing the preoperative evaluation according to the international guidelines, which are American College of Chest Physicians, British Thoracic Society, and European Respiratory Society. So first, we will be assessing the respiratory function, which are responsible for the majority of the complication after the lung resection surgery. Pulmonary assessment or respiratory assessment has to be done in three related but largely independent areas. First is the respiratory mechanics, which is responsible for delivery of oxygen from the atmosphere to the alveoli. Then pulmonary parenchyma is responsible for transfer of oxygen from the alveoli to the blood. And then cardiorespiratory interaction, which is responsible for transfer of oxygen from the blood to the tissues. Best assessment of respiratory function or any assessment, it details history of patient's quality of life. How much the patient is active, whether patient is doing a desk job, sedentary lifestyle, or patient is active, doing cyclic or swimming, patient is a farmer and doing a lot of work in daily routine. And all pulmonary resection, lung resection patients should have a baseline simple spirometry preoperatively. While doing pulmonary function, it is necessary that quality of patient performance is good and test reproducibility must be optimal and should conform to the standards. And there should specific attention should be paid to understanding the cause of abnormal tests. Any reduction in FEV1 or pulmonary function due to weakness of muscle like in myasthenia will be different as compared to the patient with COPD despite identical airflow. This is a video how we are doing PFT in our institute. Patient is well motivated and continuous feedback is being given, perform fully. And when we obtain the full rating, best rating, that is being considered for the assessment. So after the PFT, various parameters can be there which are measured, like functional residual capacity, residual volume, forced vital capacity, total lung capacity. And this is a graph picture which can be there in various physiology, like in normal or obstructive or restrictive pattern. Out of these parameters, most valued single test for post-thoracotomy respiratory complication is predictive postoperative FEV1. Predictive postoperative FEV1 can be calculated from the value of preoperative FEV1 in percentage into 1 minus percentage of functional lung tissue removed over 100. And percentage FEV1 value of less than 40 correlates with increased respiratory complication. Any value less than 40 means patient is more prone to post-surgical complications. Here we can see various lobes of the lung has been assigned a certain number of segments. On the right side, upper lobe has been assigned 6 segments, middle lobe 4 segments, and lower lobe 12 segments. And on the left side, each lobe has been assigned 10 segments, that is total 20 segments. So if we want to go for left side lower lobectomy, then 10 segment will be removed. Now 10 out of 40 to around 25, or we correctly say 24% of the functional lung tissue will be removed. If patient preoperative FE1 is 70%, then calculation 70% into 1 minus 24 by 100 will be 53%. 53% will be the post-operative predicted FE1 for this patient. After the calculation of FE1 or respiratory mechanics, we have to assess the lung parenchyma functions. Previously, for lung parenchyma function, ABG was commonly done, and any value PO2 less than 60 and PCO2 more than 45 was considered as cutoff value. But we have seen our experience that any value less than these also have a good surgical outcome. Nowadays, to measure the lung parenchyma function, DLCO is measured. This is also known as transfer factor for carbon monoxide. It is a measure of conductance of gas transfer from the inspired gas to the red blood cell. Likewise, in FEV1, predictive postoperative DLCO can be calculated from the preoperative value. And any value less than 40% correlates with both increased cardiac and respiratory complications. Correlation between the FE1 and DLCO, it is consistently poor. Reduced postoperative DLCO is predictor of cardiorespiratory complication and mortality independent of the FEV1. It has been seen that more than 40% of the patients with an FEV1 more than 80% may have a DLCO less than 80%, and 7% of them may have a DLCO even less than 40%. So both has to be calculated for any lung resection surgery. Previously, absolute value was being chosen to guide for the lung resection assessment, but it has been seen that absolute value did not predict surgical outcome as defined by 30-day mortality and postoperative respiratory failure. Value expressed as percentage of normal predicted value correlates significantly with the prognosis. The recommendation is percentage predictive value rather than absolute lung function should be used to assess the patient for lung resection surgeries. Actual major postoperative FE1 will not be same as predicted postoperative FE1 or DLCO, because in immediate period, postoperative period, measured value or observed value will be maybe less due to number of reasons. It may be due to pain, patient may not be able to breathe deeply, or it may be to surgical trauma due to chest wall and residual lung segment. Most patients will have FE1 immediately postoperative less, and after 3 to 6 months, they will improve considerably. Second, postoperative actual value may be more than the predicted value in some cases, like in emphysematous patient, where lung volume reduction will affect on residual lobe and may exceed the postoperative FE1. Then we come to the lung imaging. Prediction of post-resection pulmonary function can be further refined by assessment of preoperative contribution of the lung or lobe to be resected. And it has been recommended that any patient whose DLCO or FE1 is less than 40, less than 80%, or predicted value less than 40% should go for regional lung function imaging, which can be assessed by 3 techniques: radionuclear ventilation perfusion lung scan, VQ scan, pulmonary quantitative CT scanning, or 3-dimensional dynamic perfusion magnetic resonance imaging. In lung imaging, VQ scan is the gold standard. Here, regional ventilation is assessed by scanning after inhalation of a radio-labeled insoluble gas, and lung perfusion is assessed by scanning after intravenous injection of radio-labeled particles that are trapped in pulmonary capillaries. Quantitative CT lung scan can be used to estimate post-resection value. Each CT slice is quantified for areas of normal parenchyma, emphysema, and atelectasis. Contribution of each lobe or lung can be estimated based on volume of normal parenchyma and then used to predict postoperative lung function. Dynamic MR is the latest one and is not widely used. It estimates regional pulmonary blood volume to assess the regional blood flow. It has shown a very high level of correlation between predicted and actual value for postoperative FEVs. Then third leg of the stool, third leg is assessment of cardiorespiratory interaction. For assessing the cardiac respiratory interaction, exercise testing is gold standard. And maximal oxygen consumption, that is VO2 max, is most useful predictor. VO2 max is based on the patient age, sex, and height, and can be estimated. For sedentary males, estimated VO max is height in centimeter minus age into 20 divided by weight. For example, in 50-year male patient with height 170 and weight 70, VO2 max will be 170 minus 50 into 20 by 70, that is 34 ml per kg per minute. And sedentary women with age 50, height 160 and weight of 60 kg, it will be 26 ml per kg per minute. For cardiorespiratory interaction, it can be calculated by low technology tests or physiological testing like 6-minute walk test. This is the distance. This patient walk on a flat hard surface during 6 minutes. Patient is instructed to walk as far as possible for 6 minutes and rest it during the period is permissible. Estimated VO2 max is distance covered by the patient divided by a figure of 30. For example, patient has covered at 600 meter distance, then his VO2 max will be 20 ml per kg per minute. Current guideline does not suggest to use 6-minute walk test for assessment of cardiorespiratory interaction. Stair climbing test. Traditional test in ambulatory patient is stair climbing. In this, patient is asked to climb at his own pace but without stopping. And it is documented as the number of flights climbed. The definition of flight is variable, but usually it is taken as 20 steps and one step 6 inches height. If a patient can climb up to 5 flights, then his VO2 max is very good and it is more than 20 ml per kg per minute. And climbing 2 flights correspond to VO2 max of 12 ml per kg per minute. Any patient who is not able to climb up 2 flights of stairs is high risk for lung resection surgery. And third one is a shuttle walk test. In this test, patient is asked to move back and forth between 2 markers, which are set at the 10-meter distance. Walking speed is increased each minute in a graded fashion, paced by an audio signal. End of test is when patient is too breathless to maintain the speed. Inability to complete 25 shuttles on 3 occasions suggests a VO2 max of less than 10 ml per kg per minute, and patient is high risk for any lung resection surgery and it should be avoided. Coming on to the cardiopulmonary exercise testing, that is CPAT. It is a sophisticated physiological testing technique that provides an objective evaluation of functional capacity of both lungs and heart. Indication for ACCP guidelines has an indication for CPAT, either FE1 or DLC is less than 30%, or stair climbing test or shuttle walk test is below the threshold level, that is 22 meter or less than 400 meters. And European guidelines has recommended that CPAT should be recommended when FE1 or DLCO values are less than 80%. So guidelines here differ. Test is performed on a bicycle or a treadmill. First, testing measurements are made for 3 to 5 minutes, and then workload is incremented at a rate designed to allow to reach maximum work capacity in 8 to 12 minutes. And test is ended when either due to symptom limitation, that is severe dyspnea, or there is ECG abnormality and a test to be stopped by medical staff, or maximum predicted heart rate has been achieved. The recommendations are VO2 max more than 20 ml per kg per minute. Patient can safely undergo the planned resection up to the pneumonectomy. And VO2 max, any VO2 max less than 10 ml per kg per minute, patient is very high risk and generally regarded as a contraindication for anatomic resections. VO2 max between 10 to 15 ml per kg per minute or between indicates an increased risk of perioperative death and patient has to be counseled about the risk. Then is the anaerobic threshold. Exercise level at which lactate begins to accumulate in the blood is anaerobic threshold. It is approximately equal to 55% of the VO2 max in untrained individual. But in trained athletes, it can rise up to the more than 80% of the VO2 max. It can be documented by repeated blood lactate analysis during exercise or by threshold increase in CO2 production above the initial respiratory quotient. A threshold value of anaerobic threshold less than 11 ml per kg per minute has been suggested as a marker, but this has not been well validated. And what are the guidelines? ACCP guidelines for lung resection surgery. FEV1 value or DLCO, if it is more than 60%, patient is considered a low risk and we can go ahead for the planned lung resection. If any value, either value is less than 60% and both values are more than 30%, we go for the exercise testing, like shuttle walk test or stair climbing. If they are above the threshold values, that is, patient is considered low risk and we can go for surgery. If values are less than threshold, stair climbing is less than 22 meter or shuttle walk is less than 400 meter, we have to check the CPAT. Or CPAT is directly recommended if any value FE1 or DLCO is less than 30%. And patient has to be, decision has to be taken according to the value of VO2 max in the CPAT. Low risk patients are where functional reserves are good and can stand the stress of surgery and perform daily activity after surgery. Expected risk of mortality is below 1%. Moderate risks, here morbidity and mortality vary according to patient exercise tolerance and extent of resection, but benefit of surgery still outweighs the risk of the surgery. A patient should be explained about the risks and benefits and consult accordingly. High risk is usually taken as a contraindication for surgery, and patient may not withstand the surgery in these groups. European guidelines suggest FE1 DLCS, it is more than 80%, go for resection up to the pneumonectomy. If it is less than, if any of the value less than 80%, we have to go for exercise testing to assess the patient fitness for lung resection and take decision accordingly. So it is differing from the ACC guideline. And what are thoracic guidelines? Thoracic guideline says go for spirometry, respiratory mechanics, and DLCO. If it is more than 40%, then patient is low risk, we can go ahead for surgery. If any of the value is less than 40%, do the functional assessment. If it is good, then patient is under moderate risk, risk should be explained to the patient and we can go ahead for planned resection. If a functional assessment is also poor and below the threshold, then patient should be informed and any alternative strategy should be given to the patient. So let us discuss a case here. A 65-year-old, we have done recently, 65-year-old male patient with a history of tuberculosis was posted for right pneumonectomy. Patient has a history of smoking and hypertension. So these, when we done the PFT, these were the values. FE1 was the 1.81 liter, FVC 2.41 liter, and FE1 over FB ratio 63.3. But these absolute values are not helping us. We have to calculate the percentage predicted FE1 on DLCO, which was 36% and 42%. And as we are planning for right pneumonectomy, 22 segments will be removed. The percentage of lung segment removed will be 22 over 42 into 100. That is 52% of the lung will be removed. And if we calculate predictive possibility value according to formulas, then FEV1 comes out to be 17% and DLCO around 20%. This patient does not look fit for the surgery. Let's see. We have just assessed the two parts, two legs of the stool, FE1, respiratory mechanics, and lung parenchyma. Cardiorespiratory interaction still has to be done. We have done ABG of this patient. PO2 was 56.9, PCO2 44. We are not getting any information from ABG, whether we have to go for surgery or we should defer. So let's revisit the CT of the patient. In the CT, we can see right side of the lung is almost fully damaged by the tuberculosis. We have done the lung imaging of the VQ scan, ventilation perfusion scan for this patient. And right lung was only contributing 2% of the functional activity. The right lung was not contributing at all for this patient. So we have refined our calculation was predicted postoperative FE1 and DLCO. And predictive postoperative FE1 comes out with 35 and DLCO 41. So according to ACCP guideline, any value less than 60, we have to go for exercise testing. And stair climbing test was done for this patient. The patient was able to climb more than 5 flights of stairs, indicating VO2 max more than 20 ml per kg per minute. And accordingly, patient fall into the category of low risk. Here we can see patient was extubated on the table, and in the immediate postoperative period, patient was responding well, conscious, and comfortable in the bed. So we had a good surgical outcome. Then coming on the preoperative cardiac evaluation for thoracic patients. Cardiac complication, as we have already discussed, they are second most common. In cardiac complication, myocardial ischemia or infarction and arrhythmia are common complications. Incidence of ischemia is 5% and it usually occurs on the second or third postoperative days. Various risk score has been postulated to assess the risk. Revised cardiac and risk index has a 6 points, 1 point each for high risk surgery, then all major thoracic surgery fall in it. History of coronary artery disease, congestive heart failure, cerebrovascular disease, diabetes on insulin, or serum creatinine more than 2 milligram. And RCRI score 0 to 1 comes under low risk of mortality, 2 points moderate risk, and more than 2 point high risk of mortality. Score specific for thoracic surgery, thoracic RCRI has been postulated. Here 1.5 points are given each to pneumonectomy, coronary artery disease, and cerebrovascular disease. And 1 point is given to the serum creatinine more than 2. And points more than or equal to 2, patient is high risk. Incidence of complication can be 11 to 20%. And 1 to 1.5, moderate risk, and low risk is 0 point. The American Heart Association has given the guidelines for assessment of cardiac patient positive for non-cardiac surgery. For thoracic patient, a simplified algorithm is presented here. Patient positive for thoracic surgery with intermediate clinical predictors like mild stable angina, history of MI, diabetes, or history of CHF should go for functional capacity assessment. If functional capacity is good, we can proceed to the OR, operation room. There is no further tests are required. If functional capacity is not good or poor, so we have to assess the myocardial perfusion non-invasively. If non-invasive assessment is not possible, then we have to do CT, coronary angiography, and see for the coronaries. If they are normal, we can proceed for the surgery. If a non-invasive test is normal, that is reversibility, we can go to ORM, and in non-invasive testing, if reversibility is less than 20%, we can go ahead for planned surgery. If reversibility is more than 20%, then we have to take a decision. Either we can go for cardiac procedure intervention, keeping in mind that this patient is a cancer patient and may require surgery 4 to 6 weeks later, and accordingly bare metal stent has to be taken. Or in a case where it is possible that this lesion is such that surgery is not possible, we may proceed with diagnostic procedure only and see whether we can operate or not, and then final decision can be taken later. Second most cardiac complication is arrhythmias. Arrhythmia can be as high as 30 to 50% in patient if we monitor by a Holter, and most common arrhythmia is atrial fibrillation. There can be several factors which can lead to arrhythmia, like extent of lung resection, whether lobectomy, pneumonectomy, or esophagectomy has been done. Intraparietal resection will lead to more arrhythmias. Blood loss and age of the patient contribute to arrhythmia. And extrapleural pneumonectomy is notorious for causing the arrhythmia. Recommendation for arrhythmia is if any patient is on beta blocker, we should continue. If patient is low on magnesium, supplement it. Patient at high risk, Like patient is positive for pneumonectomy or esophagectomy, consider prophylactic therapy either with dilsam or a myotron. Thoracic epidural analgesia will definitely help in reducing the incidence of arrhythmias. Many stage 2 or 3 COPD patients will have elevated level of PCO2 at rest. It is not possible to differentiate these patients from the normal patient only on the basis of history, physical examination, or spirometry function assessment. To identify this patient, we have to go for arterial blood gas in all the stage 2 or 3 COPD patients. And in post-OPD, any unrequired high FO2 can lead to increased level of PCO2 in these patients. And also learning the baseline value of PaCO2 will help us in weaning these patients if they go to the ventilator in immediate post-operative period. So ABG may be required in stage 2 to 3 COPD patient. If any patient is having a history of smoking, then we have to encourage him, motivate him to quit smoking at least 4 to 6 before surgery. And when a patient stops smoking and more than 12 hours before the surgery, carboxyhemoglobin consumption decreases and wound healing is improved if patient continues to quit smoking more than 4 weeks post-operative. Anesthetic consideration related to lung cancer may be discussed in 4Ms. Lung tumor may cause mass effect, like it may block the airway, causing the obstructive pneumonia, lung abscess, or airway distortion, or it may compress the vessel, or maybe extend to the chest wall or mediastinal extension. Tumors may have a metabolic effect also. It may be secretory tumor also, and may like Lambert-Eaton syndrome, Cushing syndrome, hypercalcemia, or natremia. Hyponatremia may be associated with it. Tumor may have metastasized to brain, bone, liver, or adrenal. A patient may be taking for chemotherapy, bleomycin, which may be pulmonary toxic, doxorubicin, which may be cardiotoxic, or cisplatin, which is renal toxic. These all factors has to be keep in mind while assessing the patient. Then is the AFA. As an anesthesiologist, we are familiar with clinical assessment of upper VFA for ease of endotracheal intubation. Any anesthesiologist conducting a thoracic case should have the working hand knowledge of chest imaging, X-ray, and CT scan because it is important. Nobody like radiologist or surgeon will comment on the airway or issues important to anesthetists. Here we will discuss why CT is important. This is the CT scan of a patient which have a right pneumothorax and which was pushing the trachea to the left side. The trachea was deviated to the left side. So negotiating of the DLT can be tricky in this patient. This is imaging of posterior mediastinal mass in a patient which is compressing the trachea. So induction can be challenging, and if we are seeing the imaging and we assess the airway, we can better plan the induction of this patient. And this is a mass right side occupying almost whole the cavity, compressing the airway and compressing the vessels. Many major blood loss and vascular injury is expected here, and we have to plan our lines accordingly. Whether we want to put central line, we may want to take lines in the lower limbs. It all has to be kept in mind. Seeing an imaging CT scan is important before starting a case. And bronchoscopy, sometimes it may be documented or sometimes it may have to be done preoperatively to have a better picture of patient's airway. This is a video of an tracheal mass which is just above the carina. Distal tracheal mass is there. Achieving the airway in this patient can be difficult. We have to be very well conversed with patient findings while conducting the anesthesia. This is a video where mass was present in the left main bronchus. And advancement of right TLT in this patient blindly, if it goes to the left side by mistake, can cause bleeding and achievement of airway may be difficult. So if we have a Beforehand knowledge of this anatomy, we have to guide the TLT under vision to the right side. This is a video showing vocal cord palsy in a patient. The documentation of which is very important, whether it is preoperative or postoperative, and to avoid any medical legal hassle after the surgeries. To summarize, for lung resection, initially patient should be assessed for exercise tolerance and respiratory mechanics and lung parenchyma, that is FE1 and DLCO, and should be encouraged to quit the smoking. If any value is less than threshold value, we have to go for exercise testing and lung imaging to define our assessment. Any cancer patient 4M should be looked for, and COPD patients stage 2 and 3 EB should be done. After reviewing the initial assessment test result, examine the chest against CT scan, look for the airway, and assess the risk for hypoxemia during the OLV, one lung ventilation. For assessment of poor hypoxemia during one lung ventilation, poor PO2 during two lung ventilation, especially in the intraoperative period in lateral position prior to OLV, will be there. And high proportion of VQ perfusion or ventilation to the portal lung will definitely contribute to the hypoxemia in one lung ventilation. Any surgery plan for right side, definitely right side lung is bigger than the left side, can create problem in maintaining the PO2 or SpO2. Supine position and normal PFT can also contribute to hypoxemia. So this is a picture of institute where I am working for last 15 years. And I will again like to thank Dr. Sangeetha for giving me this opportunity and Dr. Meenakshi Sundaram for giving this platform to present my experience.
Thank you, Dinesh. I think you've really covered the topic, and most of the questions we'll take at the end after the complete discussion. So after this, now I'd like to invite Dr. Mandeep, who's a fellow with us in thoracic anesthesia. And he is going to present a case which came to us. So he will take us to, how we worked up this patient and how it was done. So over to Mandeep.
Good evening, everyone. Thank you, ma'am. Thank you, sir, for your kind words. Case 63-year-old male. Today I'm discussing the case of lung mass posted for lobectomy. I am Dr. Mandeep. 63-year male, farmer by occupation, presented with chief complaint of cough since 3 months, heaviness and chest pain since 1 month. Present illness cough with expectoration since 3 months, insidious in onset, gradual progressive. From last 1 month, cough severity increases, more on lying down, more on reversion, leave on taking rest, whitish color sputum, non-fall smelling, half cup per day. Breathlessness since 1 month, unable to do heavy work, no history of orthopnea and proximal nocturnal dyspnea. Chest pain since 1 month, associated with heaviness, dull in nature on right lower side, non-radiating, aggravated on coughing, not associated with any sweating, palpitations. No history of hemoptysis, pedal edema, fever, radiation, and chemotherapy. Past history. No history of hospitalization in past, no history of bypass, CPAP, not taking any medication like bronchodilator, steroids. No history of bronchial asthma, tuberculosis, COVID infection, hypertension, and diabetes mellitus. Personal history, patient smoker since 50 years, consuming 25 BD per day, that is 50 pack years, last taken 1 month ago. Occasional alcoholic, married, 2 children, mixed diet, regular bladder and bowel habits. Family history, no history of similar illness in family, no history of cancer and chronic illness in family. Occupation farmer, no history of exposure to occupational hazard, not able to do heavy work since last 1 month. After taking the patient consent, general physical examination done, patient conscious, oriented, cooperative, no dyspnea at rest, not using accessory muscles for respiration, weight 64 kg, height 170 centimeter, BMI 22, no history of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Patient afebrile, pulse rate 84 per minute, good volume, regular rhythm, no radioradal or radiofemoral delay. BP 126/74 in upright, upper limb in sitting position. ABP not visible, respiratory rate 20 per minute, saturation 97 at the room air. On airway examination, mouth opening adequate 3 finger, Mulpmatti grade 3, thyromental distance 7 centimeter, neck movement normal, no loose teeth, missing teeth, poor oral hygiene. Respiratory system, trachea central, shape symmetrical, no visible pulsation, dilated vein. On palpation, no local rise of temperature or tenderness, trachea central, apex sweet at 5th intercostal space, vocal parameters normal on all lung areas. On percussion, there was dull node on right infraaxillary area, normal resonant node on all lung areas. On auscultation, normal vesicular breath sound, decreased air entry on right lower side, vocal deafness normal on all lung areas. Bedside PFT, breath holding time of patient was 25 seconds, single breath count test is 40. CBS S1, S2, normal, no murmur, GI system soft, non-tender, normal bowel sound, no hepatomegaly, ascites. CNS oriented to time place, higher mental function normal, sensory motor function normal, skull spine normal. Summary, so it's a 63-year male, chronic smoker with no comorbidities, cough associated with copious sputum since 2 months, chest pain, heaviness on right lower chest since 1 month. On examination, there is dull node on right infraaxillary region, decreased air entry on right lower side. So the DD of the patient is consolidation, abscess, empyema, mass. As the patient show no sign of any sepsis, fever, so consolidation, abscess or empyema ruled out, and it's more towards the mass. So this is the city of the patient. In this city, you see there is a radiopaque lesion with irregular margins, and it is present on the right lower side, on the posterior basal side of the right lower lobe. So this patient posted for on further FNAC, the squamous cell carcinoma was diagnosed and posted for lobectomy. So the 4M has to be ruled out in this patient. Mass, no mass effect. As this patient has a squamous cell carcinoma, it's mostly a central lesion with having a mostly obstructive symptoms. So there is no obstructive symptom in the patient, no cavitation or any compression to any surrounding structure. Metabolic, as a squamous cell carcinoma, there is a ectopic release of the parathyroid hormone and resulting in the hypercalcemia, but there is no hypercalcemia, hyponatremia, or Cushing syndrome. Metastasis, no sign of metastasis in brain, bone, liver, and adrenal. In medication, no history of chemotherapeutic agent. So in this patient, as posted for lobectomy, further 3 leg stool approach was done for further evaluation, as already explained by Dr. Dinesh. So spirometry is done. These values as such is of no value, FV1, FVC. So percentile value of FV1 is our use, that is 74%, from which we can calculate the predictive post-operative FV1. In this, the pre of FV1 into 1 minus segment removed divided by total number of segments. It come out to be 52. So in this, the respiratory mechanics, it's 52, but single value is of no confirmed value. So DLCO of this patient is 70%. Predictive post-operative DLCO, pre of DLCO into 1 minus segment removed divided by total number of segment. As the right lower lobe is removed, so 12 segment of that divided by 42, its come out is 40. So both of the value was more than 40%. So these patients can be taken up for the lobectomy, but there are rare chances that the patient can be land up into the pneumonectomy. So, but in the last 20 years, only 5% cases are landed into the pneumonectomy, but we still evaluate further for pneumonectomy. For this, the predictive post-operative FE1 value is 35% and predictive post-op DLC value is 33%. As it's both are less than 40. So further exercise testing is needed for this patient. As the patient is able to climb 5 stairs, its VO2 max value is more than 20 ml per kg per minute, and the patient can be taken up for surgery. Thank you.
Thank you, Mandeep, for that presentation. And now I invite Dr. Mukesh, who will take us through the, intraoperative management and how we should be handling such patients who come to us. He will also be talking about the various lung isolation techniques that are there and how we should go about managing the ventilation, the protective lung ventilation, lung isolation. So over to Dr. Mukesh for his talk.
Thank you so much, Pam. Oh, the topic is designated to me as lung isolation and intraoperative management. Thank you, Dr. Meenakshi and Dr. Sangeetha for letting me for giving me the opportunity to talk on the subject, which is very close to me. As far as lung isolation technique is concerned, various equipments are available to us. Out of that, DLT, bronchial blocker, single lumen tube. Gold standard till date is double lumen tube. Bronchial blockers can be used with the standard endotracheal tube or can be contained within a separate channel inside a modified single tube such as univent tube. Selection of DLT double lumen tube is based on patient's sex and height. Female less than 160 centimeter and more than 160 centimeter, we go for a size 35 and 37 French gauge. In Asian population, we may have to go for a slightly smaller size double lumen tube for the same height because it's still not standardized for Asian population. And so is the case.
Okay, sorry to interrupt.
Yeah.
You need to share your screen, sir.
You're not able to see the slides.
No, sir. You have to share your screen, sir.
So you have to share your screen.
Is it okay now?
No, sir. We are not able to
Sir.
see your screen.
Sir, in the slide share, in the screen share option,
Yes.
you already done it, na, sir, before that you have checked.
Screen share.
Sir, the screen on the screen, sir. Yes, sir.
Is it okay now?
Yes, sir.
Sorry. So based on the height of the patient and the sex that we are going to intubate, we select the double lumen tube size. For male, less than 170 centimeter, we go for a 39 French gauge double lumen tube, and for a male of more than 170 centimeter stature, we choose a 41 size double lumen tube. Since it's difficult to determine the size of the tube just based on the height, Eberl and Associate came up with a three-dimensional image reconstruction of tracheobronchial anatomy from a spiral CT scan, which was superimposed by a transparencies of double lumen tubes to predict the proper size of right-sided and left-sided double lumen tube. So, spiral CT scan was utilized to predict a proper size of right and left-sided double lumen tube. But it's slightly cumbersome, and Seymour showed that a mean diameter of cricoid ring is approximately the same as that of left mainstem bronchus. The diameter of the cricoid ring can be easily determined by using a ultrasound. So based on that, we can very well come up with the left mainstem bronchus diameter, and then we can select our left side double lumen tube, or based on CT reconstructions, we can very well go for a proper size and proper fitting right side double lumen tube. The optimal depth of insertion for a left side double lumen tube is correlated with the patient's height. In adult, the double lumen tube insertion, the depth of insertion can be approximately calculated by adding 12 to the patient height divided by 10. So if the patient is 170 centimeter, as Dr. Mandeep said, the insertion would be approximately around 29 centimeter from the incisor. Now, the latest guidelines are video laryngoscope views are very similar to the views obtained with the Miller blade. So, a Miller blade, a straight blade, can be very well utilized to get a good laryngeal inlet view, and thus it can facilitate the insertion of a double lumen tube. Double lumen tubes are till date the gold standard, just because repositioning is rarely required. It's easy to do a bronchoscopy. Suction is easily possible. You can do give a CPAP to it, but the main disadvantage of it is size selection is slightly difficult. It is difficult to place in patients who have got difficult airway, abnormal trachea, or pediatric age group patient. Bronchial blockers, on the other hand, say ANT, Cohan, Fuji, Easy Blocker, various blockers are available, which can be utilized in pediatric age group patients as well as patients who have got a difficult airway. A univent tube is quite popularly in use. Reason being, it's a single lumen tube, and once you are planning to do a post-operative ventilation in such patients in which one lung isolation has been done, if you want to do a post-operative ventilation for such patients, you can go for a univent tube. You can just withdraw the blocker and use the same tube for post-operative ventilation as well. In few of the patients where the anatomy is so distorted that it's difficult to insert a double lumen tube or maybe a blocker, uh, reinforced tubes are also available, which can be directly inserted with the help of a fiber optic scope directly into the main bronchus. It has happened so many times. The endobronchial tubes, which are really not accessible to us, can be of some help in difficult airways where there is acute cutoff of either a left mainstem bronchus or a right mainstem bronchus just because of the mass effect of the tumor. These are the various bronchial blockers that are available in market: Cohen, Easy Blocker, Aunt Blocker, Uni Blocker. Depending on your familiarity with any of the blocker, you can go for lung isolation using these blockers. But the only disadvantage of using a blocker is you cannot do the bronchoscopy once the case has started. And second, sucking out the secretions is difficult. But their main advantage is, if need be, they can be used for selective lobar isolation. A new DLT is come into market, the VivaSight DLT. It has got an integrated camera at the end of the endotracheal lumen. So during the surgery, you need not do your fiber optic again and again. Just by connecting the camera, because of the integrated camera at the endotracheal end lumen, you can see the cuff of the endobronchial tube. And because of this reason, it's very easy to manipulate your tube. If you can see, the distal end of the endotracheal lumen will give you a sight of the as to where the bronchial lumen is lying. So and latest in this armamentarium is our ECOM DLT. ECOM DLT has got inbuilt sensors on the tracheal cuff. When in place, these sensors measure the bioimpedance signal from the ascending aorta. And when they use this information along with the arterial catheter that we have already secured, we can get the cardiac output measurements, real-time cardiac output measurements. So very soon, for high-risk cases where the patient has got a poor cardiac output, or patients where you are anticipating a sudden change of cardiac output, these tubes can be of much help. As said, the endobronchial tubes, which are modified way of normal endotracheal tube. In case you have to isolate a single bronchus using endotracheal tube, the better option is to go for an endobronchial tube, which has got a bigger length and it has got a cuff at the end, which is small and quite distally placed. So their placement is easy, and since they are reinforced tube, they are easy to place. Latest tube is anchored double lumen tube. Previously, Cullen's tube has got a used to have a hook, which went into disrepute because of the fact that that hook used to cause trauma to the carina when inserted forcefully. So this company has come up with a novel idea. Once inside the glottic inlet, all the three cuffs, they inflate this carinal balloon. And once inflated, you just have to insert it distally, and as soon as it will reach the carina, the inflated bulb will get itself engaged like a hook. Then you can just deflate this cuff and utilize your tube as adequately placed tube. You can inflate your bronchial as well as tracheal cuff. With various tubes in our armamentarium, it is still possible that you may not be able to put a double lumen tube or not able to secure a double lumen tube. So in case if it is a failed intubation with a double lumen tube, how to go about it? The option available with you is you can use a fiber optic bronchoscope or use a video laryngoscope, or else you can place a laryngeal mask here. And through this laryngeal mask airway, either you can secure a single lumen tube, or by using fiber optic or video laryngoscopy, you can use a secure a single lumen tube. And once single lumen tube is there, either you can use a bronchial blocker over there or as coaxial system, or you can use a airway exchange catheter to secure the double lumen tube in position. This same thing, difficult airway, how to go about it, same. This is the basic guideline: predictable, unpredictable, ventilate the patient with a face mask, put laryngeal mask airway, and use specialized laryngoscope or maybe a fiber optic assisted endotracheal tube or a double lumen tube. And if you are able to secure a endotracheal tube, you can very well go ahead with the bronchial blocker or exchange to a double lumen tube over the airway exchange catheter, and can initiate the one lung ventilation. Some of these patients who came up for lung resection for maybe a metastatic disease, as Dr. Dinesh said, or just because of their primary being in the larynx, for which a laryngectomy has been done, or maybe a mass that is there in the oral cavity, and the patient is on tracheostomy tube, you may not be able to put a double lumen tube through the oral cavity. So the option of putting a double lumen tube through the stoma is possible if it is a stoma is old. If it is less than 7 days old, then you may need to isolate the lung using a bronchial blocker or maybe a tube placed on the fiber optic or airway exchange catheter. So in this patient who has got a carcinoma of teeth, who hardly had any mouth opening, the airway was secured using fiber optic bronchoscope, and the lung isolation for this patient was achieved using a blocker. There is another patient where a fiber optic, under the fiber optic assistance, because of limited mouth opening, the double lumen tube was inserted. There were two persons involved. One was inserting the double lumen tube while the other one was showing the laryngeal inlet. So various permutation and combinations can be used for securing the airway, one, and for securing the double lumen tube or the bronchial blockers, you need to have a prior assessment of the airway with you so that you can see as to whether to go for a double lumen tube or a bronchial blocker or maybe a bronchial tube. Intraoperative management for lung resection. In our setup, except for the routine monitoring that we normally do for all the cases, we go in for an arterial line. CVP will depend on the baseline comorbidities. Otherwise, we secure two large bore cannulas. Pulmonary artery catheter placement is rarely required. Only in patients who have got pulmonary artery hypertension, we go for it, or maybe if we want to see for the cardiac output, then sometimes we put it. Along with that, we monitor the temperature and the urine output. And once anesthesia is induced, we have to make sure while making position that any of the dependent parts, say ear, pinna, are not compressed. And cervical spine is in line with the thoracic spine. The dependent arm as well as legs are not compressed so that neurovascular complication doesn't arise in the post-operative period. As far as fluid is concerned, we have to restrict fluid, especially in cases of lung resection. We want to keep them as dry as possible, so it's better that for first 24 hours, we should not exceed fluid more than 20 ml per kg. For an average adult, crystalloid administration should be limited to less than 3 liters in the first 24 hours. It's better not to use fluid to compensate for the third space fluid losses during pulmonary resection. An output of more than 5 ml, 0.5 ml per kg per hour is unnecessary. So we give limited fluid to such patients. For patients who have come for lung resection, and we really don't target a urine output of more than 0.5 ml per kg per hour. Anything between 0.25 to 0.5 ml per kg per hour is good enough. And if the tissue perfusion is not proper, the mean arterial pressure drops. It's better, rather than giving them fluid, put them on vasopressors or inotropes, depending on the need of the patient. The body's temperature monitoring. Since temperature is an important factor during blood coagulation, and in one lung anesthesia, its main utility is that in case the patient becomes hypothermic, your hypoxic pulmonary vasoconstriction can be inhibited. So to maintain the protective function of hypoxic pulmonary vasoconstriction, it's good to keep the patient warm using high ambient room temperatures, using fluid warmers, and upper end body forced air patient warmers. Induction of anesthesia in such patients is better done with using propofol and ketamine. Airway shouldn't be handled in a lightly anesthetized patient, since they have a hyperreactive airway, and avoid using drugs which can release histamine. For maintenance of anesthesia, propofol or volatile anesthetic which diminishes the bronchial reactivity can be used. Sevoflurane is the most potent bronchodilator out of all the volatile anesthetics. It's better, before going on to one lung ventilation, to denitrogenate these patients using 100% oxygen. Since we cannot use nitrous in patients who are undergoing the one lung ventilation, it's better that we start with 100% oxygen till we isolate our lung. As we can see, just because of the low solubility of nitrous oxide oxygen combination, the non-dependent or the deflated lung will collapse or will be will collapse earliest in nitrous oxygen combination group as compared to oxygen. But still, if you give oxygen, it is far better than using air oxygen combination. For better collapsibility, it's advisable to use 100% oxygen till you isolate your lung. Also, during period of too long anesthesia, before the start of one lung ventilation, atelectasis can develop in the dependent lung. Usually, it's advisable to perform a recruitment maneuver to the dependent lung just to overcome the atelectasis that has developed because of the position. And that can be done by using a Valsalva-like maneuver, holding the lung at an end expiratory pressure of 20 centimeters of water for 15 to 20 seconds, or at 30 centimeters of water for 6 to 7 seconds, immediately after the start of one lung ventilation to decrease the atelectasis. A pressure of 20 centimeters of water is required to recruit a fully collapsed alveoli or a atelectatic segment of the lung. As you must have seen while inflating a balloon, the initial pressure to inflate it is higher as compared to once it gets inflated. The same way, a atelectatic segment, if you want to recruit that atelectatic segment, we have to give a higher inspiratory pressures to recruit them, and once recruited, then you can switch over to a lower pressure to maintain the patency of that segment. Recruitment maintains the PO2 level during one lung ventilation. A target saturation of 90%, which is proportional to a PO2 of 60 millimeters of mercury, is commonly accepted. Brief period of desaturation till high 80s may be acceptable if the patient doesn't have any other significant comorbidity. Previously, the incidence of hypoxia or desaturation was to the extent of 20 to 25%. Nowadays, it's not very frequently seen just because of improved lung isolation techniques, routine use of fiber optic scope, improved anesthetic agent, which causes less inhibition of hypoxic pulmonary ventilation, and better understanding of pathophysiology of one lung ventilation. So our target while giving anesthesia to such patients, especially in a lateral position, is that don't use increased air, don't use high pressure to inflate your airway. Just because of increased airway pressures, you may shunt the blood to the non-ventilated lung. The same way, a decreased in cardiac output as well as a very high cardiac output can also cause uh, uh, pulmonary blood flow redistribution to the non-ventilated segments. A decrease in peripheral pulmonary vascular resistance or hypoxic pulmonary vasoconstriction may also redistribute the blood flow to the non-dependent lung. Hypoxic pulmonary vasoconstriction. It's a reflex that decreases the blood flow to the non-ventilating lung by 50%. Stimulus for hypoxic pulmonary vasoconstriction is primarily the alveolar oxygen PaO2. It stimulates the precapillary vasoconstriction, redistributing the blood flow away from the hypoxic lung region. Mixed venous PO2 is also a stimulus, although considerably weaker than pulmonary alveolar oxygen concentration. Hypoxic pulmonary vasoconstriction has got a biphasic temporal response to alveolar hypoxia. There is a rapid onset which plateaus by 20 to 30 minutes within the onset of hypoxia, and there is a delayed response, a second response, delayed response, which starts by 40 minutes and plateau up till 2 hours. This hypoxic pulmonary vasoconstriction to the hypoxic segment is also offset in a biphasic manner. And just because of this, the pulmonary vascular resistance may not return to the baseline for several hours, even after a normal oxygen to that lung is restored. This may contribute to increased desaturation during the collapse of second lung during bilateral thoracic procedures. Hypoxic pulmonary vasoconstriction is also a reflex that has got a preconditioning of it. And this second response to a hypoxic challenge will be greater than the first challenge. This is important. Once you are feeling that the patient is not maintaining his saturation on one lung ventilation, and you can reoxygenate your non-dependent or the hypoxic lung. So the second time when you will deflate that lung because of increased hypoxic pulmonary vasoconstriction, the PaO2 may get better. Ventilation increases the blood flow through the hypoxic lung more than normoxic lung. Hypoxic pulmonary vasoconstriction is inhibited by your vasodilators, nitroglycerin and nitroprusside. So if you're using these drugs, it may deteriorate the PO2 during one lung ventilation. Thoracic epidural doesn't per se affect the hypoxic pulmonary vasoconstriction, but just because of hypertension may cause fall in cardiac output and further decrease your PO2. Inhalational agents at a MAC concentration of more than 0.5 MAC start abolishing your hypoxic pulmonary vasoconstriction, and above 1 MAC they definitely come over hypoxic pulmonary vasoconstriction. So it's always advisable to use your MAC on a lower side, to keep the MAC on a lower side. Propofol or IV induction agents maintain your hypoxic pulmonary vasoconstriction. So it's always a good choice to use a combination of IV agent along with lower concentrations of inhalational agent to maintain your hypoxic pulmonary vasoconstriction. The ventilatory strategies during one lung ventilation. The goal is to maintain oxygenation, to eliminate carbon dioxide, to reduce the post-op pulmonary dysfunction, and minimize the ventilator-induced lung injury. Villi. Ventilator-induced lung injury is around 33% in major surgeries. And the mechanism could be because of volumetrauma, high tidal volume usage, barotrauma because of high airway pressures, electrotrauma because of alveolar collapse and reopening happening again and again, and because
Sorry to interrupt, Dr. Mukesh, we have to finish fast. We've already exceeded the time.
or because of the biotrauma, because of the systemic handling of the lung. So protective lung ventilation incorporates a low tidal volume or driving pressure. Driving pressure is your plateau pressure minus the peak pressure, which reduces the stress and strain on the lung. And we use PEEP to keep the alveoli open, and recruitment maneuver, as told before, deflated lung needs higher pressure to be recruited. The idea is to open up the lung and keep it open. So the ideal tidal volume that we can go in for a one lung ventilation is 4 to 6 ml per kg body weight during one lung, and 6 to 8 ml per kg body weight during two lung ventilation. It's always a good idea to maintain a plateau pressure of below 25 centimeter of water in one lung ventilation, and avoid peak pressures above 35 centimeters of water. A high tidal volume can cause barotrauma and release of inflammatory markers. It's always good to accept mild to moderate hypercapnia. Hypercapnia per se uh, um, is good for decreasing your inflammatory or the biotrauma. A PEEP of 5 to 8 centimeter should be used, and individualized PEEP can be used based on the driving pressures. PEEP should be titrated so that the lowest driving pressures are there. Driving pressure, as previously told, is the difference of plateau pressure minus PEEP. It should be kept less than 14 centimeter of water. Excessive PEEP may cause barotrauma and ventilation perfusion ratio mismatch. Mode of ventilation, pressure control ventilation over volume controlled ventilation oblique pressure controlled ventilation, volume guaranteed. Both are considered safe, and none of them provides extra recruitment maneuvers, as previously told. The FIO should we've already told about the recruitment maneuver. We should keep the lungs inflated for 20 to 30 centimeter of water for at least 6 to 7 seconds.
Excuse me, sir. Sorry to intervene. Madam, there are a lot of questions in the chat.
Yes, I think we need
It has to be answered. So we have to answer the questions so that the delegates will be benefited.
So I think.
Sorry for that. Many questions are there.
Okay. Anything? Okay. So I think it's done.
So I think Madam can take on the questions.
So thank you, Dr. Mukesh. I think it's a very elaborate topic. So if we start looking at the questions, I think okay. First, I think is from Dr. Meenakshi. To what level of pre-op workup is done in Medanta? So Dr. Meenakshi, at Medanta we have what we commonly do obviously is the PFT for all our patients who are going to come for major lung resection. And after that, on the basis of that, we are doing commonly what we do for assessing the physical status, we do the stair climbing test. And in that, we have one nurse coordinator who's there, who's with the patient, and there's a pulse oximeter which is attached. So that gives us an idea of the functional capacity of the patient. And in addition to that, if required, we do an ABG. And CPET is not done in all our patients. We do have a CPET facility, but CPET is only very specifically, when patients who are really sick or who cannot do any physical, like a stair climbing and cannot perform all that and still have to undergo a major lobectomy or a pilobectomy. And they are not even able to perform the PFTs. Then only we ask for the CPET.
Madam, why I asked that question, Dr. Sigla sir has mentioned so many preoperative testing which is available in the textbook. That is the reason I want to know whether all are relevant in managing a thoracic surgery case, especially the lung resection, or you will stop with that particular thing. Because whether you are doing DLCO, that imaging, contrast.
DLCO we only do for the pneumonectomies, not for a lobectomy or a wedge resection or a metastatectomy. And CT scan, is a must for all our patients. Without a CT, we don't take our patients. So that even the surgeon needs, so it's not a problem. So that we have for all our patients. PFT also is for either a bilobectomy or COPD patients. Even for a small resection, then we will ask for a PFT.
Thanks, madam. Thank you. Next question you can take.
The next is Dr. Kumar. PEEP, how much is kept or CPAP value? What is recommended? Okay. See, this is a very interesting question, Dr. Kumar. There is no level of PEEP which is said that this is the PEEP that we will keep. The concept that we have, as Dr. Mukesh was trying to explain, is to have an open lung concept. That is what we need to follow. So if when you do thoracic anesthesia, you will realize that there is something which is known as the inflection point. So you have a lower inflection point and you have a higher inflection point. So the lower inflection point is the point below which all your alveoli are collapsed. It's like a S-shaped curve. And the higher inflection point is the highest point above which, even if you keep giving PEEP, the alveoli are not going to open more. Our aim is to keep the alveoli in between that lower inflection point and the higher inflection point. So how to identify that? What we do is, you keep on adding. For example, you start with a 5 centimeters of PEEP, see what is the tidal volume that is being generated. Go up stepwise, like increase it by 10 centimeters, 15 centimeters, ensuring that the patient does not have any hemodynamic instability, and see how much of the tidal volume, that is how much of the compliance of the lung is improving. And you keep on increasing till the point that, yes, the compliance of the lung keeps on improving. The point at which we see that, okay, at this PEEP, there is no further increase in the compliance, that is considered the optimal PEEP. So generally, we set it at 2 to 3 centimeters less than that. So that is the adequate amount of PEEP, which ideally we should be providing to our patients. And CPAP is, yes, we we can have the CPAP valves. So you can attach that CPAP valve to the circuit and you can give it to the non-dependent lung. And if you don't have a CPAP valve, then you can just connect your pediatric circuit and open the oxygen at 2 to 3 liters. So that is also, that is not it's a way of providing CPAP. You will not know how much is going, but yes, if you just connect your pediatric circuit and switch it on for 2 to 3 liters, it is going to provide some amount of CPAP to your non-dependent lung. Otherwise, for a specific gadget, you have specialized CPAP valves available. You can attach that to the circuit and provide CPAP to the non-dependent lung. Anything else, Dr. Muthukumar, which you would like to know?
No, next, there are two more questions, madam, from the same Dr. Muthukumar. Can you explain various bedside lung function tests and how they are clinically correlated?
That I think, Dr. Muthukumar, you can go through the textbook. There are a lot of bedside, lung function tests, and that's there in all the textbooks. From match blowing to Snyder's match blowing set to whistle blowing test to, the spirometry whistle and all those things, and to voice single breath count. So these days, with the availability of PFT, you will hardly find any resident performing any of the bedside tests. You really have to tell them and ask them if they do it. And if you see, then the most reliable one is obviously, if they can hold, do the single breath count or how long can they hold the breath. Those are the two which are most easily done and the patient can follow. So usually if, they can hold their breath from more than 20 to 30 seconds, we assume that they have a good exercise capacity.
Madam, probably he would have asked whether it is practiced in routine day-to-day management.
So that's what I'm saying. I think routinely, though it's not performed, I think routinely all of them would do is just do a single breath count.
Then PEEP, you have answered that question, madam.
Yes.
How PEEP and CPAP provided. Now, Dr. Veena Asthana has answered a question. This question is for me. Can we have the recording on the YouTube? Yes, but I am working very heavily on that because the ClearNet is a scientific platform which will telecast their recordings only in their website. And I have to get a raw recording and I have to download it. Every download will take 2 hours minimum. So I have to put it overnight and I have to post it in the YouTube on my own. I can do that, but unfortunate thing is I am not having a secretary to do that. I have to do, but I am traveling continuously. And in addition to my personal work only, I am doing this, but everything will be given, I assure. So it is within time, I will download everything and I will keep it in the YouTube. So that is the answer I want to give because many people are asking. The previous episode of 52 weeks recording is available with us because that is in the year 22-23, we have arranged 52 webinars like this, one full year. That is available on YouTube because we have conducted it on YouTube. Now we have added another platform, so it is delayed. So please allow me some time. Please realize my responsibilities also, other responsibilities. So definitely I will come up with posting all the recordings which we are doing. Thank you very much in that sense. So if there is no wind up discussion from madam, we can hand over the session for vote of thanks.
So from my side, I'd just like to say one thing to all the people who are listening. See, in thoracic anesthesia, there are a few myths, and I think it's important to break those myths. And like if we begin first is with the pre-op workup, I think we need to know that it's not that we need to do all the tests. I think clinically knowing your patient, his exercise tolerance, how it is extremely important. Like the PFT, going up by numbers does not help. Your PFT may be really very bad, but if the patient has a good functional exercise tolerance, then I think it is better to rely on that than to rely on a PFT. And as anesthetists, it is equally important for us to know what a CT looks as it is for the surgeon. We cannot say that the CT is for a surgeon. We can just do an X-ray, especially when you're doing a thoracic case. So for pre-op workup, I will say to know the functional assessment of the patient and to do the CT are two very important things which we should always keep in mind. As far as the intraoperative ventilation goes, we need to know two things. That one is that obviously it is the open lung concept. So protective lung ventilation, everybody knows, but to use a recruitment maneuver before going on protective lung ventilation is what is important because that is what is going to keep your lung open. Otherwise, the patient is definitely going to desaturate or have hypoxemia once you're going to take them on one lung. So this is one thing we should always keep in mind, and always have your bronchoscope ready with you, because you never know the tube has got misplaced or it has got blocked by secretions. So you have to ensure that you keep doing repeated bronchoscopies to see what is going on. And yes, fluids we need to take care of. Give good analgesia to all your patients. These days, there are a lot of blocks available. Give your field blocks, give your SAP block, give your ESP, give paravertebral. All those blocks are there because in the post-op, the patient will recover well only if you have given him a good analgesia. Otherwise, he will develop post-op pulmonary complications, atelectasis, collapse. All those things are definitely going to happen. So a good analgesia is the only thing that is going to help you. And we have to ensure that we extubate all our patients. There is nothing like a patient who's undergoing thoracic will go intubated to the ICU. They all have to be given a trial of extubation. It is an effort. At times it takes us 45 minutes to 1 hour to just keep them on the OT table and observe them so that they are extubated. We have to give them a trial of extubation. We have to keep them on NIV. But yes, we have to keep them on BiPAP. But the aim is that 95% of the time the patient should be extubated. We should really have a very strong reason that why we are not able to extubate this patient and shift him to the ICU. So these are just the few things which I want to highlight, and some of the misconceptions that people have who don't really practice thoracic anesthesia and routine.
Then thank you, madam, for your crisp remarks. It is perfect, and the way in which you explain that shows the clarity of knowledge that is required for a teacher. That is the criteria which decides a good teacher. You are having a clarity of the knowledge, and that communication ability is important to pass on the message. And thank you very much for the communication, madam. Now I request Dr. Hema, our treasurer, ISA Puthukkottai City Branch, propose vote of thanks.
Good evening. Thank you, sir. Good evening, everyone. I thank you all for your participation in today's webinar on anesthesia on lung resection from the Department of Thoracic Anesthesia, Medanta Medicity, Gurugram. This is the 7th episode in the 2nd edition from our Puthukkottai Bhudhan series. Thank you, ALM sir, for choosing our academic chairman for choosing this topic. I thank our moderator, Dr.Sangeetha Khanna, Senior Director, Medanta Medicity, Gurugram. Ma'am, thank you for your detailed explanation for all the queries that has been raised today. Thank you, ma'am. I thank Dr. Dinesh Kumar Sigla, sir, Associate Director, Medanta Medicity, Gurugram, for your detailed explanation on the preoperative evaluation of the patient posted for lung resection with all the guidelines and assessment strategies. Thank you, sir. I thank Dr. Mukesh Kuamr, Associate Director, Medanta Medicity, Gurugram, for your detailed explanation on the bronchial tubes and the importance of physiology of one lung ventilation. Thank you, sir. I thank Dr. Mandeep Singh, Fellow in Thoracic Anesthesia, Medanta Medicity, for presenting the case for lobectomy. Thank you. Thank you, Clarinet, for your cooperation. I thank all the consultants, faculties, and postgraduates for continuous support. Expect your cooperation to increase the number of the participants in the forthcoming events. Thank you all. Good evening.
Madam, a latecomer is there. Dr. Ranga Srinivasan Chitra, he is asking how much fluids can be intraoperatively given during one lung ventilation?
Fluids, see, that is what, when you do thoracic anesthesia, you're on a tightrope walk. If you are giving too much fluids, then your lung goes down. If you restrict your fluids too much, then your kidney takes a hit. So you have to, we ideally try to follow a restrictive fluid strategy and aim that, even if for a 4-hour surgery, the fluids that we give is not more than a liter. And whatever losses happen, they, depending on the patient's hemoglobin, should either be replaced by colloids or with blood. And we don't want to over-transfuse, so our trigger is around 9. We really don't want to have a hemoglobin of more than 9. So, because obviously blood transfusion is also associated with ALI. So that is why our trigger is set at 9. So if we think that, yes, the patient is becoming unstable and has too much loss, then we give blood. Otherwise, we can just give one colloid.
Thank you, madam. And before I hand over the session to Clarinet for the concluding remarks, I want to tell the next episode will be the common topic, that is spinal anesthesia. So the anatomy of spinal anesthesia and the ultrasound guided central neuroaxis block and the troubleshootings in getting the subarachnoid block. So these three topics will be dealt in the subsequent webinar. Now the session is handed over to Clarinet for the concluding remarks.
Thank you so much, sir. We'll take a note of it. So thank you, sir. Thank you for extending us the opportunity to host a session. So with all your permission, as there are no further questions, we are signing off for today and looking forward to host you again in the upcoming session. So till then, stay safe and good night to all. Take care, everyone.
Thank you all the
Thank you so
faculty.
much.
Thank you very much for the extensive coverage. Now we will end the meeting.
Thank you so much, sir. Thank you. Thank you, dear doctors, for sharing such valuable insights.